Good morning. My name is Martin Blazer from Rutgers University. I serve as the chair of PACCARB. Welcome to the day 2 of the 23rd public meeting of PACCARB. We have an important agenda today, and I just want to introduce the co-chair of PACCARB, Dr. Michael Apley from Kansas State University. If you have any comments, Dr. Apley.
Just good morning, everyone.
Short but sweet. So now I will introduce Dr. Joanna Musmar, the designated federal official for PACCARB, who will take us through the rules of engagement and roll call.
Thank you, Dr. Blazer, and welcome everyone to day 2 of our public meeting. Yesterday, we explored the many impacts of the changing environment on AMR and infectious disease as we discussed climate change and several unique aspects. Today is a particularly special day, as we will be deliberating and voting on a recommendation report drafted by the Pandemic Preparedness Working Group, thus finalizing our current task from the Secretary regarding pandemic preparedness in AMR. We will then conclude by recognizing 16 of our council members who will be retiring, some of whom have been with us since day 1. A truly bittersweet moment as we celebrate the many accomplishments of this council and thank our dedicated leaders before wishing them well on their next chapter. Before we begin, a reminder to everyone that this meeting is being recorded. The Advisory Council is governed by the Federal Advisory Committee Act, or FACA, and as such has rules about the circumstances by which agencies or officers of the federal government can establish or control committees or groups to obtain advice or recommendations where one or more members of the group are not federal employees. The majority of the work of this Advisory Council, including information gathering, drafting of reports, and the development of recommendations, is performed by designated working groups, such as the Pandemic Preparedness Working Group, who in turn report to the full Council for deliberation and final vote, which we will see in a few minutes. Regarding the conflict of interest rules, all 15 voting members of the Council are considered special government employees and are subject to conflict of interest laws and regulations. The 12 regular government employees, or RGEs, representing different agencies and departments on the Council, have also been vetted for any conflicts of interest. They have all received and reviewed information regarding the standards of ethical conduct for employees of the executive branch. I will now go through roll call for our Council members. Please let us know if you are here by stating here. And for our alternate representative members, please identify yourself and provide the name of the principal you are representing today. All right, we'll start with our chair, Dr. Blazer.
Here.
Our Vice Chair. Ooh.
Here.
All right, thank you. Dr. Stephanie Black.
Here.
Dr. Helen Boucher.
Here.
Dr. Virginia Fate, are you with us virtually? She is. Let's make sure we unmute our council members. Thank you. Dr. Paula Fedorka-Cray.
Here.
Thank you. Dr. Christine Ginocchio.
Here.
Dr. Locke Carricker.
Here.
Dr. Elaine Larson.
Here.
Dr. Ramanan Laxmanarian.
Here.
Mr. Armando Nahum, did he join us virtually? Dr. Payal Patel.
Here.
Dr. Paul Plummer.
Here.
Dr. Julie Simzak.
Here.
And Dr. David White. Is he with us virtually?
Yep.
Yes, thank you. Moving to our liaison members, Dr. Carla Houston for the American Association of Extension Veterinarians.
Here.
Dr. Joni Sheftel for the American Veterinary Medical Association.
Here.
Ms. Emily Wheeler for Biotechnology Innovation Organization.
Here.
Dr. Lisa Marigakis for Healthcare Infection Control Practices Advisory Committee. I know she's absent. Dr. Jim Adaskovich for the Minor Crop Farmer Alliance. Dr. Jason Newland for the Pediatric Infectious Diseases Society.
Here.
Dr. Libby Dodds-Ashley for the Society of Infectious Diseases Pharmacists.
Here.
And lastly, Dr. Timothy Jinks for the Wellcome Trust.
Here.
Excellent. Now on to our RGEs for USDA. Dr. Jeff Silverstein.
Roxanne Matroni here for Dr. Jeff Silverstein.
Thank you. Dr. Sarah Tomlinson.
Dr. Chelsea Shively here on behalf of Sarah Tomlinson.
Thank you. Dr. Kiss Robertson Hale. And for our Department of Defense, Dr. Paige Waterman. All right. On to HHS, AHRQ, Dr. Melissa Miller.
Here.
Thank you. For CDC, Mr. Michael Craig.
Here.
Thank you. For CMS, Dr. Sherry Lynn. For NIH, Dr. Dennis Dixon.
Kyungmoon from NIH, here for Dr. Dennis Dixon. Thank you.
Thank you. For OGA, Dr. Jose Fernandez.
Here.
Oh, okay. All right, and for ASPR, Dr. Chris Houchins.
Here.
Excellent. For FDA, Dr. Bill Flynn.
This is Ruby Shower for Bill Flynn.
Thank you. And the EPA, Dr. Jay Garland.
Here.
Excellent. Thank you all for attending this important meeting. Just a few more housekeeping items to remember. I ask that council members who wish to ask a question during the deliberation process or have a comment to use their name card by popping it up vertically or raise your hand. And the moderator for this session, which will be our co-chairs, will call on you. Once you've been called on, please be sure to turn these off because clearly there's some feedback with the microphones. So make sure that you turn off and the red button is not there. So passing it over to our chair, Dr. Blazer, to introduce our community story.
Thank you, Dr. Musmar. Today, we begin with a most interesting story. We'll be starting by hearing from Dr. Mariah Walters, who is an epidemiologist with the Centers for Disease Control. And she'll be sharing with us the story of identifying the recent outbreak of infections due to resistant bacteria that were due to contaminated eye drops. We're excited to hear about how this story developed and how existing AMR programs contributed to the detection and tracing of this outbreak. So, Dr. Walters, can you please begin?
Great. Thank you very much for the invitation to share this story today. I do want to note that this is an ongoing investigation, and so the information I'm sharing is preliminary and may change. Next slide. Carbapenemase-producing Pseudomonas is typically extremely antibiotic resistant, showing resistance both to traditional anti-pseudomonal therapies as well as to many of our newer agents against gram-negatives. Perhaps in part because of this resistance, carbapenemase-producing strains are associated with higher mortality compared to non-carbapenemase-producing strains. The good news, though, is that currently in the United States, only a small proportion, about 2% of all carbapenem-resistant Pseudomonas harbor a carbapenemase. But as you can see on this map, there are much higher proportions in some other parts of the world. Next slide. Detecting carbapenemase-producing Pseudomonas has been an ongoing challenge. In 2021, only about 28% of U.S. hospitals were served by clinical laboratories that performed carbapenemase testing for Pseudomonas. The CDC's AR lab network has really helped to address these gaps. Starting in 2016, the network implemented carbapenemase testing in 56 public health laboratories and provided colonization screening for carbapenemase-producing organisms in 7 regional laboratories that served the country. Through these efforts, between 2017 and 2021, these labs tested more than 56,000 carbapenem-resistant Pseudomonas. We have seen even greater increases in capacity since 2021 with additional funds from the American Rescue Plan. Now, there are 26 laboratories that are funded for carbapenemase-producing organism colonization screening, and there are 45 laboratories that are performing whole genome sequencing for organisms like carbapenemase-producing Pseudomonas. Next slide, please. When carbapenemase-producing Pseudomonas are identified, CDC recommends a public health response. This includes infection control assessments and colonization screenings. And these responses are implemented by healthcare-associated infections antimicrobial resistance programs that are in 64 health departments. Collectively, these programs perform over 1,000 responses to multi-drug resistant organisms each year. And through these efforts, we've identified carbapenemase-producing Pseudomonas outbreaks linked to many different sources, but never to a contaminated product. Next slide. During summer 2022, 3 different health department programs reported facility clusters of Pseudomonas producing the carbapenemase VIM. The first was highly unusual because it was at an ophthalmology clinic and it consisted of the first carbapenemase-producing Pseudomonas from eye infections that had ever been reported to CDC. The other two outbreaks were at long-term care facilities in Utah and Connecticut. Because of the increased capacity for whole genome sequencing, CDC has advised public health laboratories to routinely sequence carbapenemase-producing Pseudomonas. And while looking at sequences for one of these outbreaks, we were able to determine that all three outbreaks were caused by the same strain and also found isolated infections in 2 additional states. Next slide. The outbreak strain had a few notable features. First, it was susceptible only to cefiderocol, which is a newer antibiotic approved by FDA in 2019. And you can see the antibiogram of a representative isolate shown at right. This strain was sequence type 1203 and had the carbapenemase BIM80 and the extended spectrum beta-lactamase GES9. This was a combination that had not previously been seen before. Among thousands of Pseudomonas isolates sequenced from US patients, ST1203 had only been identified in 5 other isolates. In VIM80 and GES9, while reported in isolates from other countries, had never been identified in the United States. All of these isolates were very closely related by whole genome sequencing analysis, suggesting that they had a common source, which we hypothesized to be a contaminated product. And because of the new sequencing capacity and the unusual constellation of features that this strain had, we were able to target this specific genotype to identify the outbreak strain among the 150 or so VIM-producing Pseudomonas that are reported to CDC each year. Next slide. We used a number of different investigation methods. We performed prospective and retrospective case finding by issuing a clinical alert over the EpiX platform in October 2022. We asked clinical labs to submit carbapenem-resistant Pseudomonas to the AR lab network for carbapenemase testing and to submit isolates that were identified with the VIM carbapenemase for whole genome sequencing. After additional eye infections were identified, in December, we issued a clinical alert to ophthalmology professional societies to amplify this message. We reviewed products used by patients through our HAI programs. These programs conducted chart reviews and patient interviews and shared their data with CDC. And additionally, they reviewed patient healthcare exposures and facilitated contact screening to prevent secondary transmission. We cultured products identified in the epidemiology investigation. Next slide. So as of March 14th, we had identified 68 patients with the outbreak strain. These patients were from 16 states, and 37 were part of 4 different facility clusters. They had a median age of 61, but ranged from less than 1 to 102 years old. Their cultures were collected between May 2022 and February 2023 across a variety of clinical settings that included acute care hospitals, long-term care facilities, and outpatient clinics. And patients had many different specimen types. 38% were from surveillance sources identified through colonization screening, 26% from eyes, and 35% from other clinical sources, which included urine, sputum, blood, and a few other body sites. Next slide. So most of these patients had at least one serious underlying condition. And the most common underlying conditions really varied by the specimen source from which the case was identified. So 77% of patients identified through surveillance cultures had chronic lung disease or the clinical condition of respiratory failure, which is consistent with most of this screening happening in high acuity post-acute care facilities where many patients are mechanically ventilated. Among patients who had cultures from anatomic sites other than the eye, 1/3 had chronic lung disease or respiratory failure, and 1/4 had diabetes. And among patients with cultures from the eye, 89% had eye disease, most commonly glaucoma or cataracts. Next slide. So this slide shows patient outcomes for all patients on the leftmost column, and then among the subset that had clinical cultures in the right two columns. 60% of patients had a new hospitalization related to their culture, and among those with cultures from sites other than the eye, 55% went to the intensive care unit. 3 patients died, including 1 with bloodstream infection and 1 with an eye culture. Among the patients with eye infections, 8 had vision loss with the eye preserved, and 4 underwent enucleation, which is surgical removal of the eyeball. Next slide, please. So we used many different investigative approaches to try to find common products used by this group of patients that really didn't have a lot of overarching commonalities. We conducted a case control study at a long-term care facility that had the most cases, and found that cases had a 5 times greater odds of exposure to artificial tears than controls. This was noteworthy because none of the cases at this long-term care facility had eye infections and was relevant in light of another cluster of eye infections. We were unable to differentiate the exact brands of artificial tears received by most patients at this facility, but ultimately were able to determine that EzriCare artificial tears had the largest purchasing volume of any brand, and so that many patients at this facility who were receiving artificial tears likely got this product. We were then able to narrow in for the other facility clusters on artificial tear use. We now had 4 clusters, including 2 with eye infections. We determined that EzriCare artificial tears was used across all of the facilities, and among patients in this cluster, 76% used artificial tears, and 85% of those used EzriCare. For the 31 patients who were not linked to clusters, 63% used artificial tears, and among those, 69% reported using EzriCare, including all 8 patients who had eye infections. EzriCare artificial tears is a preservative-free formulation that was dispensed in multi-dose vials and distributed nationwide over the internet. It was manufactured in India. Next slide. Using the epidemiologic evidence, we were able to gather opened product through our HAI programs, and CDC ultimately tested 23 open bottles from 5 lots in 2 states. 11 showed bacterial growth, and the outbreak strain was identified in 7 bottles from 4 lots in 2 states. Now, testing of open product cannot differentiate between intrinsic contamination and extrinsic contamination, and so FDA is testing unopened bottles of EzriCare currently. Next slide. We compared isolates from patients in open product using whole genome sequencing. This phylogenetic tree has isolates colored by the state that they're from, and product isolates are noted in squares and patient isolates in circles. These isolates differed by 0 to 24 SNPs over an approximately 93% core genome. We identified 3 clusters of patient and product isolates that differed by 0 SNPs, and these are shown in the gray boxes. The box at upper right is the largest of these clusters, and it includes product isolates from 2 states and patient isolates from 5 states. Next slide. Based on the mounting epidemiology evidence, we initiated a series of public communications. This began on January 20th with a clinical alert through EpiX warning against the use of EzriCare due to potential contamination. Shortly after this alert, the product was no longer for sale at Amazon and Walmart. On February 1st, we issued a HON and a companion website, and the following day, Global Pharma, the manufacturer of EzriCare, issued a voluntary recall, and FDA posted an alert. Next slide. So these are some epi curves to help us understand how this outbreak unfolded. And we have the top panel showing cases by date of specimen collection, and the bottom by date of confirmation, and these are colored according to the case culture type. So this outbreak appears to have started in May 2022 with 1 to 9 clinical cases per month through February, and the eye infections seem to be fairly uniformly distributed throughout this period. But the bottom panel helps us understand how case confirmation lags specimen collection. It, of course, does take time for isolates to be identified and sequenced. But additionally, many cases, especially those from eye infections, were reported retrospectively after the clinical and public health alerts. We have had a few cases reported to us from after the recall. These patients primarily appear to be patients who have used EzriCare before the recall or had epidemiologic links to known cases. And we are, of course, conducting ongoing monitoring for cases. Next slide, please. So in summary, CDC, working with the AR Lab Network and our HAI programs, identified a large outbreak of resistant Pseudomonas that was linked to artificial tears, and is the first time in this country that a carbapenemase-producing organism outbreak has been linked to a contaminated product. The success of this investigation was directly due to having a national coordinated effort between public health laboratories and HAI programs, which enabled us to rapidly identify and investigate these cases. And I really cannot understate that having HAI programs provide infection control support and the AR Lab Network support colonization screening helped mitigate secondary transmission. This was clearly a complex investigation, and we needed to use multiple lines of evidence to get to the outbreak source and our public notifications and product recall. And it's really important to recognize that transmission of extensively drug-resistant organisms through a widely distributed over-the-counter product will present new challenges for containing the spread of these organisms. Next slide. So let's look ahead. Controlling pathogens that are traditionally associated with healthcare is going to be further challenged by exposures in reservoirs outside of healthcare, and I think we're seeing that in this outbreak. This outbreak also showcased how whole genome sequencing of resistant pathogens can be a critical tool for addressing antimicrobial resistance threats. But we also need to build on what we've learned from this outbreak and figure out how we improve surveillance for these uncommon carbapenemase producers, like we see with Pseudomonas, and how we shrink timelines for whole genome sequencing. And then in order to use this laboratory information effectively, we need to sustain our pandemic investments in public health epidemiology and infection control so that we can prevent transmission and infections. Next. So this work was the product of my many fantastic colleagues at CDC, in our health departments, in public health laboratories, and at the Food and Drug Administration. Thank you.
Thank you, Dr. Walters. We have some time for some council questions and discussion. And Dr. Blazer, I see you up first.
Yeah, Dr. Walters, thank you so much for telling us this story. It's a remarkable story, and I would like to congratulate you and your colleagues for saving vision and saving lives. And this is really the value of prospective epidemiologic studies. So it's a terrible story, but it's wonderful how you can imagine that if you hadn't found this would have just continued. Especially with all those unopened bottles that continue to show the organism. So I have two questions. The first is very short, and that is that enucleation is a relatively rare medical event. Have you or colleagues counted the rate of enucleation in the United States before and during the outbreak? That's the first question. And the second question is just to get an idea of how extensive this was. And the second is, can you give us some clues as to why this product in eyedrops, this contamination of eyedrops, led to sputum, urine, and blood infections? Can you postulate that?
Yeah, so starting with your first question, we have not looked at the rate of enucleation nationally. That is certainly an interesting question. And as you point out, this was probably one of the most catastrophic outcomes for these patients. And I think it's a great question about how can an eye drop cause, for example, a bloodstream infection. And so there's two pieces to this question. First, certainly we know that the tear ducts are connected to the upper respiratory tract and the lower respiratory tract. And so that you can imagine if patients are receiving artificial tears, especially patients who are already quite sick, who are perhaps mechanically ventilated, they're in a long-term care facility, that bacteria is eventually going to colonize the airways and from there potentially colonize the digestive tract, and we're going to seed infections at other sites. So I think physiologically there's a plausible explanation for that. There's also the piece of secondary transmission, right? Not all cases in this outbreak received artificial tears, although we think that is ultimately the source of this outbreak. And that is because we know that there is person-to-person transmission of this organism. And in fact, historically, that is how we have seen this spread. And so there is also, the fact that some of these patients probably got this organism from other patients and essentially got infections because of, whatever their risk factors were for infection at a certain site.
And just to follow up on that, were the artificial tears used in those long-term facilities where there were patients who did not have that exposure?
There were, yes, I think if I understand your question, right, and I think that's what we really saw with the case control study, right, is that we saw an association with artificial tear use, and we actually saw that most patients in the facility did not receive artificial tears. But there were some instances, patients that we suspected actually were secondary transmission, did not receive artificial tears, but had a clear link to another patient.
Dr. Boucher?
Thank you. Dr. Walters, great job. Really outstanding presentation and story, scary. And I was going to talk about the secondary transmission risk and just highlight the infection control issues of that, right? A patient with multi-drug resistant Pseudomonas in our hospital is on full isolation. Obviously, none of these people could be. I just think that can't be highlighted enough, sort of some of the links that we don't really even think about that were at play here. The other comment I have is about antibiotics. So seeing Cefidrocal as the only susceptible, the only drug to which this organism was susceptible, and your comment that it was a new antibiotic. It is the newest antibiotic we have in America, approved in November of 2019. We just can't emphasize enough, there have been 0 antibiotics approved since November of 2019 in our country. And this case illustrates the potential calamity that we're going to have if we don't address that. So thanks very much.
Dr. Laxminarayan?
Thank you, Dr. Walters. That was incredible and incredibly sad as well that it happened at all in the first place, because it came on the back of a number of other cases where there have been sort of challenges with products that have been coming out of pharmaceutical factories in India. Now, I guess that artificial tears would not be the natural place to look for bacterial contamination, right? This would not have been on FDA's radar. Is anything going to change with the practice of inspections and looking for bacterial infections into products that enter hospitals, but are not necessarily blood or blood-related products, given that there's potential for transmission in this way?
That's an excellent question, and I would need to defer to my FDA colleagues who have the regulatory authority for these products.
All right. Mr. Craig?
Thank you, and a couple things that I just wanted to magnify, and I want to thank Dr. Walters. And first off, I also want to say, Dr. Walters, this is sort of emblematic of what CDC can do and what we expect CDC to do as the disease detective sleuthing and the collaboration with state health departments. And I also want to underline that these are the same folks, the folks who uncovered this outbreak are the folks who were also on the front lines for COVID-19. These are the same folks who are going into nursing homes and supporting state health departments. These are the folks like Stephanie and her team in Chicago. And when we talk about the report and when we talk about the language that we put in the report of linking pandemic preparedness to what we do on AR, and the sustainability that we put in, the sustainability language that we put in there for public health staff, as well as AR Lab Network, this is emblematic of it. Because one thing that I do want to be very explicit about, if we did not have those supplemental resources for ARP, this outbreak would still be going on, and we would not have detected it, and more people would have lost their lives and lost their eyes. And if we don't have sustainability of that, that capacity, specifically for things like whole genome sequencing and colonization screening, is going to go away, and we're going to go backwards as a nation in terms of our preparedness for the next AR pathogen or introduction of other emerging infectious diseases. So I want to thank the Council for what we're going to talk about after this for the report, because this is emblematic of exactly that capacity that we're talking about. The other thing that I want to really focus on here that I think is a game changer that I don't think has been captured in the news stories about this, and that I think we as a council have to be very concerned with, is prior to this outbreak, this was a rare pathogen, right? Whenever we see these, we tell healthcare facilities that they have to act fast. As Helen said, if a hospital sees these, they have to isolate this patient because we're talking about something that is rare, highly transmissible in a healthcare environment. What we saw with this is that rare pathogen was effectively packaged and shipped globally around the world, and it was distributed widely in nursing homes in the US and in other places. There are probably still a lot of contaminated product out there. It was sold by Amazon, it was sold by Walmart, and we're going to, we haven't even, you know, the 68 cases that were noted here, we know there are more. That's the challenge. The other challenge that we face, and this is why I flagged some of this yesterday in the decolonization conversation, is exactly about that secondary transmission. The other challenge that we're going to face is that this is actually going to go on for years, because people who did not get an acute infection here are likely going to be colonized, and they're going to be in these healthcare settings. And that secondary transmission is going to continue. So we're likely to see this outbreak strain being transmitted in nursing homes, in hospitals, in other settings, literally for years to come. And that's a major concern. Like, this is probably going to make it so that we as a country might be dealing now with this strain being endemic. So it was something that was rare. It could be something that we now have to deal with moving forward. And if we're not prepared to address that, and if we don't understand that, that's, you know, a major issue. And I think that's the other piece where we talk about decolonization. If we can come up with new tools that are not antibiotics, but that are decolonizing agents. I agree with Helen's comment that it sort of points to needing more antibiotics, but it also points to needing prevention products. Because if we can decolonize these individuals of this pathogen, that will be a game changer in stopping that secondary transmission, in stopping this from moving forward.
Dr. Newland?
Dr. Walters, thank you so much for you and your colleagues, and to also elevate what Michael said. CDC has been tremendous in so many efforts and didn't get enough credit during the COVID-19 pandemic. As a pediatrician working alongside them in schools, it was heartwarming, and learned a ton from you all, so thank you for this. To build off of what Dr. Boucher mentioned, is Cefidrocol being the only drug that it was susceptible to, and is, you know, there's no new approved. I'm curious how many people actually within this got treated with Cefidrocol, or maybe had to be transferred to a place in order to get Cefidrocol, because, you know, if you're in a small community hospital, my bet is they don't have Cefidrocol or have no idea how to use it. So do you guys have any sense of who were able to be treated that needed to be treated?
Yeah, it's something that we're trying to gather more information on now. We're taking a much closer look at the clinical course of these patients. As you can imagine, during the investigation, the focus is on the source. And so that is an excellent question and one we're following up on.
Dr. Ginocchio?
Thank you, Dr. Walters. Tremendous job. I have two questions. Have there been, first of all, cases reported outside of the United States? Like we said, I would imagine that this has been sold globally. And maybe because it's India, it might be a little bit more difficult, but are you may or may not be able to actually track the source of where the contamination came from in the manufacturing process, to better understand and maybe for prevention? And how common is this isolate in that area of India, say, where the manufacturing is made?
Yeah, great. There's a lot there, and I will try to unpack. Before we go to the source, the first question was about cases from around the world. And so I do want to just clarify that, no, we have not had other cases reported. And while Global Pharma our understanding is that they are a contract manufacturer and provide services to many countries, our understanding based on the recall is that this product was only sold in the US. And so that's consistent, not seeing those cases. And then this particular strain with, the carbapenemase, VIM-80, the GES9, that combination of features had not been seen anywhere. So I think we can't comment on, how common this is in India. We do know that there are reports from that region of isolates, both with VIM-80 and GES9, but really we couldn't use the molecular information to deduce where this might be coming from. We do know that there are reports of carbapenemase-producing organisms in the environment in India, and based on that, we hypothesized that the source of this outbreak was probably an environmental source in the manufacturing plant. We don't have more details, though, on how exactly this became contaminated, and it is a question that we would like to know more about.
Dr. Jinks, then Dr. Blazer, and that will conclude our session.
Great, thank you. So I want to echo the congratulations and thanks for the successful investigation and the fact that early intervention must have saved lives as well as eyes and exposure to unnecessary morbidity. My question actually ties back to a bit that Michael Craig said, but I would like you to reflect on the situation with respect to innovative tools as well as the capabilities to conduct these kinds of investigations for outbreaks. And, what would happen if it weren't something that were very rare, but in fact were more common and the molecular sleuthing becomes more complicated? So what tools ideally are needed? How much capability do we really need here so that there can be sustainability? And as kind of a corollary question, given the situation as it stands right now, is there enough capacity for a sustainable response to try and get this under control? I mean, Michael's painted a terrible picture that now the U.S. has yet another now endemic, highly drug-resistant pathogen. Can we maybe capture that one and contain it? Thank you.
Yeah, so I think first I just want to highlight one of the things you mentioned about this is a rare pathogen, and we probably found this because it is a rare pathogen. And I think that's sort of one of the hidden values of the work we do on these unusual resistant organisms, where there are many sources. We can think back to the duodenoscope issue, issues with colonized sink drains in healthcare facilities, where we're able to identify this broader issue because we have these rare organisms where we can separate the signal from the noise. In terms of approaches, I think that we probably need to rethink how we approach HAIs in terms of the molecular analyses. We have typically thought of these as transmission is local. It's in a hospital. It's in a patient sharing network. So we haven't necessarily adopted some of these approaches used for other pathogens like foodborne illness, where, yes, salmonella is common, but we're able to identify these strains. And so I think one of the tools is simply not just building the capacity to do sequencing, but building the systems to really look at those data on an ongoing basis to identify outbreaks. And, I think the picture can feel bleak with AR. We get, and I know Dr. Black can attest to this, we get, so many reports of concerning resistance, and it doesn't feel that unusual when you're in the trenches getting these reports every day. And I think one of the ways that we really need to start addressing this is not waiting for a case to act, right? Like, I think of containment as it's whack-a-mole. It works really well when those moles are coming up slowly and you can whack each one. But why are we waiting screening for cases in facilities that we suspect could have a high prevalence of these organisms that are at risk of importing these and having transmission, because they're caring for patients who have high acuity, they have long lengths of stay. So these are like our LTACs, our ventilator-equipped skilled nursing facilities. And so something we've done as CDC and used some of these additional funds for is really to promote prevention strategies. So proactively working on infection control and screening at these facilities so we can identify patients who have these organisms and prevent their spread.
Dr. Blazer.
As you know, some of us are coming to the end of our term on PACCARB, and your outbreak reminds me of two of our important goals. One is the goal of stewardship, and the other about international efforts, and this really highlights that. And I want to point out about stewardship because it is antibiotic pressure that is driving the emergence of these organisms, both at the source and also at the level of the patients. And that antibiotic pressure is something that is very much in the center of this council. Now, I just have one question, which is to Dr. Craig. So what's going to stop on May 11th? What has to be done so that we can keep things going?
You mean with the end of the emergency pandemic notice? So actually in terms of what we're talking about here, it doesn't affect that level of funding. It affects a number of other things, and we can certainly talk about those, and I think there is, partly some time later to discuss some of those pieces. The funding issue that we have for the American Rescue Plan is that money has been appropriated by Congress, and it will go away in FY26. And so for some folks, they'll be, well, that's years away. But the reality is if we don't start talking about that and showing the value and proving the value of that money now, which is what we're doing with this outbreak and this conversation, it's going to go away. And I think even if we do that, it still might go away. But I think we need to make it very clear that if it goes away, it has a cost. And as a country, we're going to either pay now, and we're going to pay for these resources so that we're going to be prepared, or we're going to pay later with wider spread of these rare pathogens and less preparedness overall for the next emergency outbreak. But in terms of May 11th, it won't directly impact a lot of the pieces that we're talking about today.
Thank you.
Dr. Walters, thank you for your presentation and sharing your expertise with the council. Dr. Musmar.
Thank you, Dr. Apley, and our appreciation once again for CDC joining us today to share in this story, this amazing story of discovery. All right, moving on to our task. We're switching gears a little bit, and now we're going to focus back on hearing from our Pandemic Preparedness Working Group. I just want to have a special thanks for not just our working group chairs, Drs. Ramanan Laxminarayan and Joni Sheftel, but the writers of the report in support of the chairs and the working group, Ms. Sarah McClellan and Dr. Marcus Mirchek, and the rest of the team, of course. I'll pass it over to our Pandemic Preparedness Working Group chairs.
Hello, everyone. Good morning. I'm Joni Sheftel, liaison from the American Veterinary Medical Association to PACCARB, and co-chair of the Pandemic Preparedness Working Group with Ramanan Laxminarayan. We are so proud to present the report of the working group for deliberation and vote by the council today. Slide 2, please. PACCARB stood up the Pandemic Preparedness Working Group in response to a task from the Secretary to see how antimicrobial resistance, infection control, and stewardship could be integrated into existing pandemic preparedness policies and plans using a One Health approach. The working group began its work in May 2022. As part of the year-long study of the issues and the report development process, the working group hosted 2 public PACCARB meetings along with additional information gathering sessions with key subject matter experts from across the One Health spectrum. Next slide, please. The Pandemic Preparedness Working Group developed a mock pandemic scenario to serve as the basis for discussion during the September 2022 public meeting, the first of the 2 public meetings. In this fictional scenario, a highly transmissible novel influenza A strain with unknown origins was spreading through both the human and the swine populations. Human hospitals were over capacity, and swine health was affected also, both by the virus and by a depleted animal care workforce. Within the scenario, mortality was associated with a high rate of resistant secondary infections. We asked participants to speak about what they would do if faced with this mock scenario in real life as a way to highlight potential gaps in our current pandemic preparedness policies and response. Next slide, please. There were several major themes that came out of the September PACCARB meeting. Most importantly, investing in a steady state operations is a critical element. As we saw during the COVID-19 pandemic, many necessary everyday functions of healthcare and public health were halted to divert necessary resources to meet the demands of the emergency at hand. Antimicrobial stewardship suffered. Many antimicrobial resistant infections went undiagnosed or untreated due to a lack of a robust enough steady state system to handle a pandemic surge. Investing in these systems is needed to make sure that they are appropriately staffed and have the capacity to provide the necessary reserve and remain resilient during an emergency. Secondly, in the setting of the mock scenario, our presenters emphasized the importance of flexibility, especially in regulations, to allow for a rapid deployment of resources. Flexible regulations are also necessary to allow for non-clinician providers to help support the demands of a health emergency and avoid workforce shortages. And as exemplified in our mock scenario, emergencies are not experienced in isolation. Even without an animal component to the infectious agent, our mock scenario would have impacted animal production and our food security due to worker shortages, much as it did during the COVID-19 pandemic. It's important that pandemic preparedness takes a One Health approach and includes a holistic perspective to be truly robust and resilient. As a reminder, One Health is an approach to problems in which the health of people, animals, and the environment are considered all together, the needs and risks are balanced, and the outcome is optimized. The importance of health communication, especially during a crisis, and the impact that health equity has on how different populations experience a public health emergency were major themes that continue to come up throughout the meeting and throughout our committee's work. To dive further into these critical concepts, we decided to hold an additional public meeting that would focus on communication, health equity, and health disparities. Next slide, please. The PACCARB met virtually in January 2023 to focus on the issues of communication and equity as they relate to responding to a pandemic or other public health emergency. Animal health and human health experts shared communication challenges and best practices during rapidly changing health emergencies. Other presenters discussed the unique challenges faced by vulnerable and marginalized communities during a public health emergency, such as we just experienced with COVID-19. Several broad themes emerged from the January public meeting. First, there's a lack of trust in public health, which is exacerbated by a lack of access of some communities to health care, even during steady state operations. And second, there's frequently poor transparency in routine and certainly in emergency public health communications, and the specific needs and concerns of marginalized and vulnerable communities have not been adequately considered in pandemic preparedness planning. These findings led to recommendations 1 and 2 in the draft document to prioritize interventions that build trust in public health and to include marginalized and vulnerable communities during the planning, development, implementation, and communication of pandemic preparedness policies. Now I'll turn over to Dr. Laxminarayan.
Thank you, Dr. Sheffield. It's been a real honor to co-chair this working group with you and with all the other, and working with all the other members of the Pandemic Preparedness Working Group, and also with Sarah McClellan and Dr. Kazmierczak, who've done a fabulous job on this report. Picking up where Dr. Schefter left off, following the public meetings and the additional information gathering sessions, the Pandemic Preparedness Working Group worked collaboratively to develop what we hope is a thoughtful and actionable report with recommendations. Now, the scenarios that we worked on were primarily about secondary bacterial infections in the event of a viral pandemic, but it is just as likely that the pandemic itself could be bacterial in nature, just back to the days of older epidemics like for cholera, for instance. Fortunately, we don't deal with these now because of the availability of effective antibiotics, but that threat always is in the background, that we could actually have a fully bacterial pandemic as well. We also considered the potential for secondary fungal infections, which was seen in some parts of the world during the COVID pandemic, and what we've heard at this meeting again about the potential for fungal pathogens is, lends more weight to the importance of that set of recommendations. So in response to the direct ask from the Secretary, the working group focused on two primary pieces of existing pandemic preparedness policy, the AP3, the American Pandemic Preparedness Plan, and the National Biodefense Strategy. The working group closely reviewed these documents to determine how they can be modified to include antimicrobial resistance. In addition to this narrow purview, the working group also looked at other ways in which these policies could be augmented to ultimately create a more robust health system before the next public health emergency. So, next slide, please. So the infographic on the screen is from the report and is a visualization of how the report itself is structured. So there are four main categories of recommendations: infection prevention and control and antimicrobial stewardship. The second is workforce expansion. The third is data sharing and security. And the fourth is product innovation. Within each category of recommendation, there's further subdividing into recommendations that should be enacted and invested in during steady state, which are non-emergency times, and recommendations that investments are needed now but will be mobilized in the event of a public health emergency. We cannot emphasize enough the importance of investing in policies now. This was repeated during all of our discussions, and it needs to happen well before the next pandemic to ensure that our health system is more resilient when the next emergency strikes. As denoted in the slide, this is a major theme of the entire report. And in addition, you will see that equity, trust, and communication sit at the heart of these recommendations. Even when not explicitly stated within the report or in every section, all future pandemic preparedness must include the input of marginalized and vulnerable populations. And as demonstrated during the COVID-19 pandemic, vulnerable and marginalized populations were disproportionately impacted during the public health emergency, and that was and is unacceptable. Addressing health disparities starts with inclusion. Every recommendation put forward here reiterates that need and should be implemented with the inclusion of these populations. And certainly the building of equity, trust, and communication is through all populations, and that also needs to start right away so that one thing we did learn was you can't actually build trust in the middle of a pandemic. You have to have it or you don't have it when the pandemic strikes. Next slide, please. So here are the recommendations. So the next three slides run through the 14 recommendations that were put forth in the report. Each of the recommendations are further elaborated on and expanded within the body of the report. The first two recommendations are about what I just mentioned, the overarching themes of promoting health equity and inclusion of marginalized and vulnerable populations. So to prioritize interventions that build trust in public health guidance and, of course, include marginalized and vulnerable communities. The next two recommendations then outline the necessity to include specific antimicrobial stewardship guidelines that are adaptive to an emergency situation. As was seen during COVID, during an emergency, infection prevention and control and stewardship must be maintained, yet are often hindered in an overwhelmed health system. It is therefore critical that specific guidance be created so that frontline health workers are prepared even in resource-constrained situations. And there's a steady state element to it, and there's certainly an emergency operations element to it where we have to create that mechanism for rapid guideline development on what the appropriate antimicrobial use should be during an emergency. Next slide, please. So as seen during COVID, the frontline workforce is crucial to our efforts to combat antimicrobial resistance as well as during a public health emergency. As it stands, our workforce is not adequately staffed nor adequately supported to face another pandemic. The infection prevention workforce is essential, and innovative and flexible incentives have to be implemented now to ensure that we're recruiting and retaining talented practitioners in all fields, not just doctors, nurses, healthcare workers at all levels, to make sure that there are staff available when the next crisis hits. Bolstering our surveillance and data systems is also a crucial part of not only detecting the next emerging public health threat. I think we just saw that, and also the comments that were made by CDC, but also tracking its spread so that we can better target our resources during an emergency. If we don't know it's there, we can't really respond. Our health data are a key part in this, as we know that disease does not spread in a silo. Many of the data systems have been developed to track resistance and were quickly utilized to track the spread of COVID-19, but at the expense of their steady-state work. That is not enough. We need systems that can handle the capacity of a surge while maintaining their daily work, as they are both critical facets of a resilient health system. Next slide, please. Our final recommendations focus on product development. A huge milestone in our fight against COVID-19 was the rapid development of a vaccine. But that is not an option with the development of new antibiotics, because the timelines to develop new antibiotics are much longer than for a vaccine. And we're already at a deficit when it comes to a development pipeline for antimicrobials. Therefore, it is necessary that we invest in the development of these products and other innovative products now, well before we're faced with our next public health emergency. And as they're already difficult to incentivize, as we've discussed many times at council meetings, we need to also have new and innovative diagnostics and, of course, drugs in our arsenal prior to when they are needed. So with that, that ends our presentation of the report. Over to you, Jemana.
Thank you. Drs. Lakshmanarian and Sheftel, we appreciate it. I'll now open it up to the floor to see if there are any last-minute comments or edits. We have Dr. Marquez Mirchek here. If there are any significant edits that need to be made, we will make them live so that they're stated for the record before we transition to a vote. Do any of the council members have any comments or statements to make in reference to this report?
Of course, as a member of the working group and a member of the council, I should be excused for being self-congratulatory. But I think a really important aspect of the report is the centrality of the issues of trust and communication, which go across all the other issues. And as we've learned from COVID, that is such an important issue in medical politics today in the United States and elsewhere. And I think it's really important that we have emphasized that. So thank you.
Dr. Jinks.
Thank you. And I will offer my congratulations for you so that you don't have to be self-congratulatory in this. It's a fantastic report. And the recommendations, I think, are very important here. It's very complicated in terms of what the task was and how to break that down into actionable recommendations. I particularly applaud the fact that putting equity and trust in the heart of this is an important thing. However, I think there's a missed opportunity, and we could go further in making sure that the recommendations are more practical and implementable here. The fact is, who's against equity and trust, right? I mean, these are things that when you look at it at face value, there will be strong agreement. That's important. And, of course, we must be doing that. So I wonder if we can make it a little bit more crunchy, a little bit more actionable, and ask for more accountability from U.S. government, because these are recommendations to U.S. government here. So can we make it clearer that it's not just that we want to see that state of equity and trust, but in fact, in all of the actions that are undertaken by U.S. government, they should be equitable in what is being done, and that they should be trustworthy. And this is very different. It might seem like a bit of wordsmithing, but I think it's very important that the recommendations do place that accountability to U.S. government in its interventions and actions that it might do. And can we really reinforce this message of the importance of that centrality by placing more responsibility to the U.S. government by calling this particular aspect out. And you know, I think it cannot be stated enough, because the most vulnerable people are in those communities which suffer from poverty and racism. And we should look for opportunities to actually connect things to anti-poverty interventions as well as anti-racist interventions that are ongoing. And it comes out pretty well in the body of the report. But the high-level synthesis, the tear sheets, what's really going to be read, I feel like is a little bit too broad to really get the traction that we might want to have. And 2 points I want to make in the specific recommendations. Number 2 says to plan for. Now, taken in isolation, a plan to do nothing ends up being an excuse to do nothing. And I think if we just drop the words plan for and ask for inclusion of marginalized communities, that can make a very big difference. That is actionable.
Dr. Jenks, just to clarify, are you asking for edits directly into the document now before we vote on it?
Yes.
Okay. Could you be specific as to what page number and line so we can make the edits live and Dr. Marquez-Mirchek can make those?
All right.
Actually, excuse me, Dr. Jenks, if you're talking about recommendation 2, we did make that change in response to your emailed comments.
Okay. So I guess it's a version control.
I can read the recommendation number 2, which is include marginalized and vulnerable communities during the development, implementation, and communication of all pandemic preparedness policies.
Perfect. Thank you. So then I will jump forward then and want to check. Maybe the version I looked at was also not updated. Recommendation 12, and that is one on develop novel antimicrobials, vaccines, diagnostics, etc. And in the body of the recommendations, it talked about some specific tying in to assigning AMR as a material threat. Has that been updated?
It has. Let me read it.
Okay.
Recommendation 12 is develop novel antimicrobials, vaccines, diagnostics, and threat-agnostic platform technologies focused on resistant bacterial and fungal pathogens, which are material threats likely to arise during a PHE, public health emergency.
Okay. Well, thank you. And then only on that one, I just want to check with the council if such wording identifying material threat is sufficient, because it's very clear as a mechanism of mobilizing activities in the U.S. government, having AMR identified as a material threat is clearly critically important. So are we clear enough in this statement so that that action might be considered and done by U.S. government? Thank you.
Thank you, Dr. Jenks. And I know that there is a recommendation that elaborates on asking for AMR to be considered a material threat within that section. It's pretty straightforward.
But it's buried. And I just want to make sure that it really comes out. While this is a public meeting, we know that the reports don't get read closely by all of the actors that we wish would. And so I want to make sure that on something like this, which is immediately actionable and which could have very profound effects, can actually be picked up.
So with that said, because it is already within the recommendation, would it be satisfactory if we just included that as part of the executive summary to be a little bit more direct?
That would help.
Okay. All right. Because that doesn't change the essence of the recommendations, we can make that edit afterwards, after the vote, because it is part of the body of the document. It's just a matter of reformatting, and that'll be considered a reformatting component that won't affect the vote. Any other concerns that we, all good? All right. All right, Dr. Boucher.
Thank you. Following along, Dr. Jenks, I just want to call out again the workforce issue. We need more Dr. Walters, right? We need more Dr. Walters today, and we certainly need them before the next pandemic. And I just want to raise for the council's consideration just one last look at recommendations 5, 6, 7 and make sure we think they're strong enough. It's a crisis, right? We had the worst match in infectious diseases in decades this year. People are not entering the specialty. So, Elaine, go ahead. Go ahead. Yeah. So I just want to make sure people think this is strong enough language.
One option is that we could simply add the word epidemiologist in the example of the healthcare professionals that we need to assure are sufficiently available.
Just so that everyone's on the same page, Dr. Kazmierczak, can you please read out recommendations? Is it 5, 6, and 7, Dr. Boucher?
Recommendation 5 is bolster the workforce by expanding recruitment and support of infection preventionists and infectious diseases specialists and engaging a broader set of providers in human and animal health care. Recommendation 6 is develop pathways that would allow for qualified practitioners in other One Health domains to provide support to human health care during a PHE, public health emergency. And recommendation 7 is build capacity for both human and animal diagnostic laboratory networks to meet emergency surge testing demands.
So just to clarify, the recommendation structures as we've had them are usually catch-alls because the content is a little bit more detailed. Do those 3 satisfy, or is there any wordsmithing that we need to add on? Because keeping it tight is always a challenge.
Yeah, I would suggest we could add infection preventionists, epidemiologists, and other infection prevention experts, whatever, in recommendation 6, just adding that one
Does that
word
satisfy?
as an example.
So the
Is
edit,
it 5? Wait a minute, let me see.
for recommendation 5, adding
Expanding-
epidemiologists to the other 2 professional categories.
No, yeah. Right, recommendation 5. Sorry.
Dr. Kazmierczak, can you read that back to us so everyone hears it for the record with the edit made?
So that would be bolster the workforce by expanding recruitment and support of infection preventionists, epidemiologists, and infectious diseases specialists. And
We could say other infectious disease specialists.
and other infectious diseases specialists, and engaging a broader set of providers in human and animal health care.
Any edits to that line? Dr. Black?
Well, I was just going to say instead of epidemiologists, something like public health professionals, because those are the group that encompass all of the story, the national response that Dr. Walters so nicely described.
So maybe we start with public health professionals because we get specific then with infection preventionists, which are part of that category, wouldn't they be?
Yes.
Okay.
And that is discussed in the body
Yes.
of the work, but to capture it in the...
Does that satisfy your concern, Dr. Boucher?
Thank you.
So Dr. Kazmierczak, could you once again switch out epidemiologists and start with public health?
Yes, so the final recommendation would read, bolster the workforce by expanding recruitment and support of public health professionals, infection preventionists, and other infectious disease specialists, and engaging a broader set of providers in human and animal health care.
Are we good?
Sorry,
Go
not
ahead.
quite. So, so infectious disease specialist needs to be in there as a group. I think they got lost, or they became other. But it should be infection preventionists, epidemiologists, infectious disease specialists.
So you want to remove the word other?
Yes.
Okay. So we have support of public health professionals, infection preventionists, and infectious diseases specialists.
Great, thanks.
Dr. Black, did you have a comment? Oh, no? Okay. Any other concerns about any of the recommendations? The main recommendations? Going once, going twice? All right. Dr. Kazmierczak, other than the addition, just for the record, of us adding AMR as a material thread to the executive summary, we have completed the edit to recommendation 5. It's been read on the record, and now we will commence the vote. And this will only go to our special government employees. I'll ask Drs. Virginia Fate and David White to let us know their vote virtually. All right, Dr. Blazer, do you agree to the transmission of this report to the Secretary of Health and Human Services and turn to the President of the United States?
Yes.
Dr. Mike Apley?
Yes.
Dr. Stephanie Black?
Yes.
Dr. Helen Boucher?
Yes.
Dr. Virginia Fate?
Yes.
Thank you. Dr. Paula Fedorka-Cray.
Yes.
Dr. Christine Ginocchio.
Yes.
Dr. Locke Carricker.
Yes.
Dr. Elaine Larson.
Yes.
Dr. Ramanan Lakshmanarayan.
Yes.
Mr. Armando Nahum is not with us today. Dr. Payal Patel.
Yes.
Dr. Paul Plummer.
Yes.
Dr. Julie Simzak.
Yes.
And lastly, Dr. David White.
Yes.
All right. Well, not so much unanimous vote because Mr. Armando Nahum could not be with us, but I will try to get his vote by proxy later on. I believe this report will be transmitted to the Secretary.
I'm just happy to add that this is the latest of our reports, all of which have been approved unanimously. So this is really a mark of the council of us all working together so collaboratively. Thank you.
All right, folks, we are done a little bit early, so in anticipation of our leadership to join us, we'll take a 10-minute stretch. Please, please, please be back by 10:25. And those of you in virtual land, we will be back shortly, so please don't leave your seats. Thank you.
Well, welcome back, everyone. It is my pleasure to introduce Deputy Secretary Andrea Palm to our council. As the Deputy Secretary, she's the Chief Operating Officer of the Department of Health and Human Services. Ms. Palm most recently served as Secretary Designate of the Wisconsin Department of Health Services, where she led the state's response to the COVID-19 pandemic. Deputy Secretary Palm, thank you for being able to attend today and join our event. Thank you.
Thank you. We have to like peek at each other. It's quite a setup. Thank you, Dr. Blazer, for that introduction and certainly for the invitation to join all of you here today. I want to really thank the members of this austere, august, whatever the right A word is, body. PACCARB really is a critical advisory body for HHS as we think about these really critical issues. We have found since your inception in 2015 really important recommendations and input to how we think about this really critical issue. I'm not telling you all anything, but here in the U.S., our Centers for Disease Control and Prevention estimates that every year we see 3 million infections and 48,000 fatalities due to drug-resistant bacteria. Globally, it is estimated that 4.9 million deaths were associated with drug-resistant bacteria in 2019, including over 1.2 million deaths attributable to bacterial AMR. In addition, the ongoing COVID-19 pandemic and our response has added yet another complexity, sort of all across the board. Everywhere we look, COVID-19 has added to the 3D chess that we're playing in the healthcare space, and AMR is no exception to that. We've really seen a dangerous uptick in the overuse of antibiotics during the pandemic, and that hospital-acquired infections really on the rise, and deaths increased by 15% between 19 and 20. So again, really seeing an exacerbation of the issues we all are facing jointly on this issue because of the pandemic. So we recognize that the challenge ahead of us is not small, and that our ability to really double down and do the work that's needed in this space is critical. So again, really sort of standing on that foundation, immensely grateful for the work that you all are doing, and that you have been so responsive, particularly to the Secretary's request that you think about our current pandemic preparedness policies as you bring additional recommendations forward to us. Because focusing solely on the viral component of the next public health emergency is really missing the mark of being able to fully look at what we need to do to be prepared. So again, much appreciation for the thoughtful way you all are looking at the issues of pandemic preparedness for us. PACCARB's newly approved report provides a set of thoughtful and actionable recommendations to position HHS as we think about this moving forward. And I want to highlight two other priorities that I think we saw woven throughout this report that are important for us, for this administration to really take note of. The first is equity. It's a priority of this administration, and we really work here at HHS to embed that concept in all the work that we are doing. And so when we think about preparedness, when we think about this issue, when we think about equity in this space, we really emphasize what is a truth in all of healthcare, that if we're all not protected, if we're leaving the most vulnerable behind, we are all not protected. So we've got to raise all boats in this space as well. The second one really is this concept of One Health approach, and that perspective. Climate change, the continued warming of the climate, really is consequential for the conversation around AMR, and will create new public health challenges for us and exacerbate ones that exist. So really want to acknowledge the importance of what really is an interconnectedness among the issues that we face, and even though climate change might, from a mission perspective, belong predominantly in other parts of the U.S. government, we have a critical role to bring to bear our expertise and our work in this space to mitigate AMR and other issues that are exacerbated by climate change. Finally, I really want to acknowledge the retiring members of this council. Some of you have been here since 2015, since the very beginning, and you've really helped shape our domestic and global response to AMR, and your mark will be on the work we do moving forward. So I really want, on behalf of this administration, the President, the Secretary, really express our appreciation for all of your contributions to this advisory committee. So again, many thanks for inviting me to join you here today. The recommendations you make in this report and that you have made throughout this committee's existence have been super helpful to us, and really are important for our ability to successfully meet the public health challenges ahead of us. So I think I am turning it over back to you. All right. Thank you all again for having me.
Thank you so much for joining us today, Deputy Secretary Palm. We appreciate your words of encouragement, and I'm sure on behalf of the entire council, your presence here is already testament to honoring our council members, and we're truly thankful that the ASPR could be with us today, since she's been with us since day one. So while we still I
don't go anywhere without the ASPR.
I wouldn't either. While we still have lots of work ahead of us, the progress that has been made since the inception of this council, as you mentioned back in 2015, is truly a testament of the dedication and leadership of the members of PACCARB that they provided to this nation and our global partners. It is with a full heart and my utmost appreciation that we retire our 16 committed members today and wish them well as they continue their critical work and continue to tackle AMR-related issues. To honor their outstanding service, we've invited the Assistant Secretary for Health, Admiral Levine, who will be joining us virtually, and we are honored to have you both again here. You've seen our ups and downs, and I want to personally thank all of our members for this journey, for dedicating your time, dedicating all of your efforts towards this important work, and to also serving as mentors to me and our team. We've learned so much from all of you, and I'm honored to have had you along for the journey, and your absence will definitely be felt, but I have your numbers, so you will be contacted. Don't forget. PACCARB will continue to look to the future and honor their achievements by charging forward and pushing through the many facets to combat AMR as we fulfill our role as an advisory council. So with that, I'd like to introduce the Assistant Secretary for Health and Human Services, Admiral Levine, who has done a pre-recording to honor our members. And just briefly as an introduction, Admiral Levine serves as the 17th Assistant Secretary for Health for the United States, Department of Health and Human Services, and is the head of the United States Public Health Service Commission Corps. She fights every day to improve the health and well-being of all Americans. She is working to help our nation overcome the COVID-19 pandemic still and build a stronger foundation for a healthier future, one in which every American can attain their full health potential. To provide more Americans with high-quality health care and better health outcomes, Admiral Levine is also collaborating with federal agencies to advance HHS's action plan to strengthen primary health care, along with the department's Equity Action Plan. Admiral Levine's storied career, first as a physician in academic medicine, focused on the intersection between mental and physical health, treating children, adolescents, and young adults. And now I present to you Admiral Levine's recording.
Thank you, Dr. Musmar, for that kind introduction, and thank you, PACCARB members, for welcoming me to another public meeting.
Technical
While
difficulties?
I regret that I cannot join you in person, it is an honor to again speak to this council. I am here to recognize the continued commitment to stopping the spread of antimicrobial resistance. I would like to acknowledge the value of the work your council has produced over the last 7 years. That hard work is apparent by the many members of the department's leadership here to honor your efforts. And I echo Secretary Becerra's gratitude and interest in the work of this council and the work that is finalizing today to advance the nation's pandemic preparedness. As the Biden administration has announced that the public health emergency declaration for the COVID-19 pandemic will be ending in May, we have an opportunity to evaluate our past efforts and further reflect upon the lessons learned. The pandemic highlighted many pre-existing societal issues, including health inequity. While health disparities are not new, the emergency brought significant attention to this topic and allowed us to gain a deeper understanding of the many impacts of health and health equity. It is the goal of both the Biden administration and our department at HHS to focus on achieving health equity in our country, and I am heartened to hear that these goals are upheld in the work of this council. Since we last spoke, I am pleased to know that your previous public meeting in January was focused on both communication and health equity, as well as the experiences of vulnerable populations during an emergency. Highlighting these important topics is critical for an effective pandemic response in integrating marginalized communities into pandemic preparedness, and this is critical to eliminate health disparities. Just as the COVID-19 emergency magnified gaps in accessing care, underserved groups continue to experience unique challenges and complications when combating AMR. It is critical that we maintain transparency during the often difficult conversations that are needed to make progress on this complex health threat. I encourage you all to keep pushing the envelope so that we may be even more prepared in the future. Our nation's public health depends on it. I look forward to reading the thoughtful and vital recommendations this council will be putting forward, and I want to thank each council member for their diligent and dedicated work that will help to make our nation more prepared for the next pandemic. With that said, it is with the utmost gratitude and commendation that I would like to convey my and Secretary Becerra's sincerest thanks to the 16 retiring PACCARB members. Many of you have been with this council since its inception, and your contributions have been instrumental to the continued fight against antimicrobial resistance. You have ensured that this department continues to be a leader in addressing this significant problem. It is with the most sincerity that I say thanks to Drs. Apley, Blazer, Boucher, Dodds-Ashley, Fedorka Cray, Ginocchio, Houston, Jinks, Carricker, Larson, Laxminarayan, Maragakis, Newland, Sheftel, Wheeler, and White. Secretary Becerra and I are continually grateful to you for lending your time and expertise to this council. I would also like to personally recognize Dr. Martin Blazer for his role as the chair of the PACCARB and Dr. Michael Apley for his role as vice chair. The leadership that you have both provided to this council has driven us to explore and champion innovative ways to combat antimicrobial resistance. You have provided knowledge and expertise with such strong commitment to this fight. Your presence on the council has been invaluable to the success of PACCARB. And I am excited for this council's next chapter as we await the confirmation of some returning as well as new experts to this prestigious group. As a small token of our appreciation, each retiring member will receive a letter and certificate commemorating your time and contributions to the PACCARB. Our ASPR, Don O'Connell, will present these to you personally on my behalf. I also have the honor of welcoming the new chair of the PACCARB. Congratulations, Dr. Paul Plummer. He is the Executive Director of the National Institute of Antimicrobial Resistance Research and Education, which is housed at the Iowa State University. Your devotion to combating AMR from a One Health perspective and commitment to the efforts of this council will make you an excellent chair. We are excited to see the direction that you will lead the PACCARB in the future. I want to recognize that we are all here, myself included, because we have all collectively experienced the traumas and continued impacts of COVID-19. Each of you are experts who are driven to help people, and that motivation is apparent in the participation and engagement that you have invested to this council as we continue to bolster the nation's preparedness plans. Antimicrobial resistance is a persistent, multifaceted issue that sits at the critical intersection of our public health and pandemic preparedness systems. I hope that the department's continued support of your efforts empower you all to continue to ask the hard questions and push the boundaries as we tackle this complicated problem. I look forward to seeing you continue to approach antimicrobial resistance in creative and novel ways. It is now my pleasure to introduce HHS's Assistant Secretary for Preparedness and Response, Ms. Dawn O'Connell. She brings many dedicated years of service to HHS. As the ASPR, Ms. O'Connell oversees the coordination of interagency activities between HHS, other federal agencies, and state and local officials responsible for preparedness and the protection of the civilian population from public health emergencies. Thank you so much for being able to attend today, Ms. O'Connell.
Well, thanks to Admiral Levine for that wonderful introduction. Thank you, Deputy Secretary, for being here, and Chairman Blazer, Jomana. You all have learned a valuable lesson. Don't invite me to a PACCARB meeting unless you want me to come, because I always say yes. So this is the second time I've been able to be with you during my tenure as the ASPR, and it is always a treat. And as I mentioned last time, during my time as Deputy Chief of Staff at HHS, in fact, it's fun for me to say, Andrea was the Chief of Staff at the time. So back in the Obama days, I had a chance to work on the CARB initiative on behalf of the Secretary. And one of my responsibilities in that work was launching PACCARB. Jomana and I spent many hours with Bruce Gellin and others around my little table in the Deputy Chief of Staff's office, working through the details and the agendas of that first meeting and picking many of you to participate. It's hard for me to imagine that it's been 7 years since that first meeting, and I want to thank all of you, the council members and public audience, for being here these last 2 days and contributing to this nation's preparedness for future AMR threats, continuing to emphasize the importance of antimicrobial resistance and pandemic preparedness. Since the enactment of the Pandemic and All Hazards Preparedness Act in 2006, ASPR has led the nation's medical and public health preparedness for, response to, and recovery from disasters and other public health emergencies. As a newly designated operating division, and I can't remember if we were an operating division the last time we were together, but this happened last summer, we'll continue in this role, and our recent reorganization has strengthened our capabilities to mobilize in the event of emergencies like the COVID-19 pandemic. ASPR is dedicated to bolstering our preparedness capabilities to a sweeping number of deadly threats, including AMR, one of the scariest, as we talked about last time. We recognize the accelerating speed of the so-called silent pandemic, as drug-resistant microbes create unique challenges and magnify existing gaps in the U.S. healthcare system. Through the Biomedical Advanced Research and Development Authority, or BARDA, ASPR continues to encourage public-private partnerships to maximize the research and development of antimicrobial products through programs like CARB-X and Project BioShield. With antibiotics not only being a revolutionary component to modern medicine, but a vital component of our nation's response capabilities, the discussions and insights shared by this Council are more relevant now than ever before. My office is looking forward to receiving the upcoming recommendation report as we anticipate your timely guidance. And while several members from this committee are retiring their PACCARB post, this work will live on, and for that I'm grateful and very proud to be a part of this effort from the start. Jomana, are we going to do certificates? How will the next part of this?
In the interest of time, we've actually placed the certificates on their table, so you can keep rolling with the, with the readout.
So my next talking points are to thank you all, of course, the 16 retiring members, and to have you raise your hand and be acknowledged. Now, I know that Admiral Levine just went through names as well, but I'd be happy to do that too. So let me thank all of you for all that you've done, and make sure that you each are recognized and are able to raise your hand so we know where you are. So I'll start with Dr. Michael Apley, who has served as Vice Chair, Dr. Helen Boucher, Dr. Elizabeth Dodds Ashley, Dr. Paula Fedorka Cray, Dr. Christine Ginocchio, Dr. Carla Houston, Dr. Timothy Jenks, Dr. Locke Carricker, Dr. Elaine Larson, Dr. Ramanan Laxminarayan, how'd I do? Dr. Lisa Muragakis, okay, not here. Dr. Jason Newland, Dr. Joni Sheftel, Dr. Emily Wheeler, Dr. David White, who is attending virtually. Great. And lastly, I would like to personally acknowledge Dr. Martin Blazer, as not only serving as an active member, but for his role as chair of the PACCARB since its establishment back in 2015. Thank you sincerely for all you've done, for your leadership in developing this council into what it is today. And let me congratulate the new chair, Paul Plummer, who brings a wealth of experience and expertise to this council. We are excited and look forward to the great achievements of PACCARB under your leadership. And to the retiring members, the entire HHS community is overwhelmingly appreciative of your commitment and engagement with this council. You have contributed your guidance and esteemed knowledge to this institution and have transformed the way this nation approaches AMR-related issues. In this, you should be proud. While your time with PACCARB has come to an end, I know your dedicated time and leadership are far from over. Dr. Blazer, I'll now turn over to you for some final comments.
Thank you very much. I'd like to thank Admiral Levine, Secretaries Palm and O'Connell. Dr. Apley, do you want to make a couple of remarks, and then I'll just conclude?
Thank you. I just want to reiterate that our work continues for those leaving the council in promoting the work of the council and informing the council of news, advances, and challenges in our respective areas. I know my participation in the council over the 7.5 years has changed my perceptions of our collective challenge of AMR and has deepened my personal resolve in addressing the antimicrobial stewardship within veterinary medicine. I thank you all for the opportunity and best wishes to the council.
Thank you very much, Dr. Apley. I want to just make my concluding remarks. I want to say it's been a long time since we started, but we have accomplished a lot together, including today's report, which I think is maybe the best. And I'm very pleased that all of our reports have been signed unanimously. And we've been able to achieve consensus despite many differences amongst us, but we have. And so I personally want to thank many colleagues, those here today on the council, on the staff, those who've passed through the council in years past, the administration of HHS. It's been a great run, And it's time to pass the baton on to the next generation, Dr. Plummer and others. And so with that remark, this meeting is now adjourned.
Council members, please join the ASPR and Deputy Secretary Plum at the stage for a quick group photo, please.
Produced by the U.S. Department of Health and Human Services.